Today I'll be talking about patella femoral pain syndrome. Patella femoral pain syndrome is an umbrella term that's used for the pain that arising from the patella femoral joint itself or adjacent soft tissue. It is also also known as runner's knee. It is often referred as anterior knee pain and patella femoral pain. The term is at some extent used as a diagnosis of exclusion once the intra-articular or peripatellar pathology is excluded. Some brief anatomy for the patella femoral joint. It is an articulation between patella and distal femoral condyle. The joint itself had its sliding articulation with 6 degrees of freedom. The patella tracking is defined by sliding, medial and lateral, glide, superior and inferior, and third, medial and lateral. The static stabilizers for the joint is MPFL, patellotibial ligament, and medial lateral retinaculum. The dynamic stabilizer would be vastus medialis and vastus lateralis muscle. The blood supply is from the geniculate artery. The function of the patella femoral joint is to transmit the tensile force generated by the quadriceps tendon to the patella tendon. It also increases the lever arm of the extensor mechanism. The patella femoral joint reaction force increases up to 7 times when squatting, and it increases up to 2 to 3 times when going down the stairs. The patella move caudally during flexion. At the initial flexion, the patella translate 4 mm medially to engage with the trochlear groove at 20 degree of flexion. As the flexion progress, the patella translate about 7 mm laterally until by the time it reach 90 degrees of knee flexion. The maximum contact between patella and trochlear groove is at 45 degree of knee flexion. There are a long list of differential diagnosis of the patella femoral pain. Can be divided into acute, chronic, and constant pain. For acute patella femoral pain, the differential would be disruption of the extensor mechanism, patella instability, patella fracture, chondral injury, osteochondral injury, or infection. For the chronic pain, chronic patella femoral pain, the differential would be idiopathic patella femoral pain syndrome, patella chondromalacia, osteoarthritis, inflammatory arthritis, ITBS, and also patella tendonitis. For the constant patella femoral pain, the differential would be complex regional pain syndrome, neuroma, or oncologic process. There are 4 major contributing factors for the idiopathic patella femoral pain syndrome, which include malalignment of the lower extremity or the patella, the muscle dysfunction or imbalance of the lower extremity, the overload or overuse injury, and trauma. For the history part, we should take a comprehensive history from the patient. Usually, patient will complain of anterior knee pain or patella instability, and the pain usually aggravated by activities such as running, going up and down the stairs, and sitting for a long time. And then we should explore more on the specific activities that cause the pain, because we can tackle those problems during the management part with activity modification. For the physical examination, full knee examination should be done. On inspection, we can look for pes planus, genovalgum, femoral interversion, and also excessive pronation of the foot, which might increase the risk for patellofemoral pain. We can also look for inverted J sign for sign of patella matracking. On palpation, there might be tenderness over the medial and lateral patellar facet. There might be capitis, and there might be patella stiffness or hypermobility. Besides that, the RM could be normal or limited due to pain. The special tests that can reproduce the pain, we can do Clark sign or patella grinding test, and then the test that we can do for to aggravate the instability, we can do patella apprehension test. The other test we can do is over test to test for the ITB tightness, because ITB tightness can also cause joint pain and also the patella maltracking. For the imaging, we can do X-ray, epilateral, and motion view. We can look for osseous morphology of the patella or the femoral, the joint itself. We can also measure the patella height using a few techniques, insensitivity ratio, black bumpy ratio, or catenism ratio. We can also look for trochlear morphology based on Dijo classification. For the CT, we can it is useful to calculate the TTTG value, and then for the MRI, it is useful to evaluate any soft tissue injury or chondral injury. The management of the patellofemoral pain syndrome, it can be divided into non-operative and operative. For the non-operative, usually is the mainstay of the treatment. In non-operative management of the patellofemoral pain syndrome, the main target is to reduce the pain, to improve patella tracking, and also to return to the previous level of function. There are few treatment options for the patellofemoral pain syndrome, which focus on the activity modification, muscular strengthening, balance and proprioception, tapping or brace, orthotics, electrotherapy, and pharmacotherapy. For activity modification, if patient previously a runner, we might suggest the patient to change to activity that have low impact on the knee, such as swimming or cycling. The use of proper footwear also is very important, and then we can also change the treatment regime to reduce the risk of overuse injury. For muscular strengthening, the main important muscle that needs strengthening is the quadricep, especially the VMO. We can teach patient to do asymmetric quadricep contraction, SLR with abduction or adduction. The other muscle that also needs strengthening is include hamstring curl. We can do the other muscle that need strengthening is also hamstring. We can do hamstring curl. For the gastrocnemius, we can do calf raises, and then for the gluteus, we can do hip around the world with the band. And then the other stretching, we can also do the ITB stretching to reduce the ITB tightness. For balance and proprioception, we can do single leg balance, and then progress with eyes closed and throw ball. For tapping, we can do mechanotapping, and brace, we can ask patient to wear J brace. Orthotics is also useful for patient with excessive pronation or flat footers. For electrotherapy, it is also useful for pain management and also for muscle activation. We can use phonophoresis, TENS, and also EMS. For pharmacotherapy, we can use NSAIDs, either oral or topical, to reduce the pain. Oral, we can suggest for Celebrex and Votrient. For local, we can use keto patch or Vorengel. We can also offer patient for muscle relaxant, for example, Myonal, and we can also offer intra-articular injection such as prolotherapy, steroid, or HA. For operative management of patellofemoral pain syndrome, it is usually reserved for patients that have a significant disability, despite the use of non-operative modalities for minimum of 6 months. The arthroscopic arthroscopy is one of the choice. It can be done for diagnostic or therapeutic reason. Thank you.